Welcome everyone to the latest in our series of knowledge mobilisation webinars delivered by the NIHR. My name is Lindsay Bean and I am co-hosting this webinar with Helen Baxter. We are Senior Research Fellows in Knowledge Mobilisation at the NIHR Evidence and Dissemination Team. We're delighted to welcome today Professors John Gabbay and Andrée. John Gabbay and Andrée are Professors Emeriti at Southampton University and recent implementation leads for the ARC East of England. They have worked together researching, writing and teaching about the use of knowledge in shaping service change and delivery for over 20 years. So thank you, John and Andrée. I'll hand over to you now.
Hello, and thanks very much for inviting us to talk to this group. We're really pleased to be able to do that. We're going to be talking today about how you engage practitioners in what we like to call a relational approach to mobilising research knowledge. And one of the reasons we want to do this is because it is now beginning to show that this method may well work. I'd like to introduce you to, and by the way, the thumbs down is not about the implementation gap politics in the USA. It's about what actually happened to Dr. Epling and his colleagues in Virginia. They were working in primary care and they noticed that through audit, they were getting very poorly controlled diabetes in their practices. They had a research-based approach which they call lifestyle insulin visits, emotional care, and their audit showed that this simply wasn't happening. So what did they do? Did they introduce some guidelines? Did they introduce a new protocol? No. Did they do CPD sessions? No. Did they introduce an IT alert? No. Did they introduce some kind of financial incentives or quality improvement method? No. What they did was none of these, but what they did seemed to work. These are the outcome measures, and that's the point of the intervention, and you can see that things suddenly got better. And what they did simply was this: a one-time informal practice discussion around evidence-based interventions, which they found could generate the kinds of discussions that may lead to the development of mindlines. Well, what on earth are they?
Well, we're going to tell you that later on in the session. But before we start, we'll tell you about, very briefly, the research areas that we've used. You can see these up here. We've been researching this area since 2000. We've got multiple sorts of research studies that we've used. We have had multiple funders. We've included, and we ought to say thank you to them. Thank you very much, funders. And we've included a jolly good spoonful of autoethnography, reflecting on 4 decades of our own experiences as researchers, practitioners, and educators struggling with evidence-based practice. So our research methods are informed by a multitude of theories and frameworks, and you can see them all here. We cannot, over that time, pick one solid theory or framework that we use. They are multiplicitous. But our methods for collecting data revolve around ethnographic work, case studies, action research, all of which are interactive, iterative, participative, developmental, and as you'll see as we carry on talking, relational. And finally, we spent the last few years of our career actually implementing for real when we worked in the ARC in the east of England, and we'll talk a little about that too.
There is a naive view of research implementation, which I'm sure none of the over 100 people who are now present here still believe, but people did believe it until relatively recently. This very linear idea that you create knowledge, you validate it, you disseminate it, you implement it, and there it is, getting practiced out there. The real world is very different, and this diagram is actually based on data that we collected from working with groups of people way back in the year 2000, 2001, when they were trying to develop policy based on research for looking after the elderly in the community. We gave them the research, and this is what they did with it. They didn't just accept it or put it into practice. They batted it around in all sorts of different ways, as you can see here. Because of this problem in the real world, there have been all sorts of implementation methods and theories and frameworks that people have come up with, which are shown here. some examples of them, from CPD through change management techniques, through issuing guidance, to improving leadership, participatory techniques, financial incentives, and all the things that Dr. Epling didn't use. Many models and frameworks, and by the way, on the East of England Art website, you'll find lectures on the ones here on the right from our knowledge implementation fellowship that we had. They're still available if you want to listen to some of the people who developed these, like knowledge to action and experience-based co-design and so on. The one we're going to talk today about is our own model, if you like, the mindlines model.
So we're also going to tell you a little bit about the 4 circles framework that we use as well. This is devised from looking at all the literature around the models and frameworks to do with implementation and the movement of evidence into practice. As you can see here, to get successful implementation, we would suggest that you need to focus on 4 things. We're not the only people to suggest that, by the way. The first is the evidence, the second, the context, people, obviously, terribly important, and then how you change and make things different. So first of all, remind you about the evidence. This will be absolutely familiar to you. Evidence needs to be relevant. It needs to be relevant to the context it's being implemented in. It needs to be robust. It needs to be critiqued, and it needs to be ready to move into practice. So you need to begin to think about, has it been used elsewhere, and how has it been used and accepted elsewhere? In relation to that, closely tied together with evidence as a context of the organisations into which the evidence is going to be implemented. The context in terms of the inner context, resources, skills, capacity, local politics, all impact on the implementation of evidence, and the outer context demands on the organisation, the wider politics, the general social, cultural milieu outside the organisation. Importantly today, though, we're going to focus on the target people. We're going to focus on practitioners, although this is, of course, a group of people who go way beyond practitioners, who include policymakers, patients, their families, etc., all of whom you're well aware of. And I believe you have had and you will have some more seminars in relation to. So who are these people? And what do they actually do in their practice? Well, what we found is from our research on mindlines in general practitioners' practices, that they have multiple roles: clinical roles, managerial roles, public health roles, professional roles, and they're doing all of these roles at once. So it's very important to understand the context and what they actually do in their everyday jobs. So,
for example, in the clinical domain, a doctor or a nurse might be diagnosing, prescribing, and investigating, and that's what the guidelines tend to be about, the guidelines that come from NIHR or elsewhere. But at the same time, as we were watching the practitioners, we saw they were also having to manage their resources, to monitor quality, to comply with contractual and legal requirements, to engage in health education or some screening or some preventive work, or to make sure that they were keeping up to date, that they were nurturing their collegial networks, and all those other things that go on, which the guidelines don't actually talk about and don't take into account.
So once you know who they are and what they're doing, you need to know what they think. What do they already think? What do they know? And what evidence do they base that thinking on?
The sources of evidence are multiple. We, of course, have the national and local policy and the guidance and so on, but we also have our own experience, the experience of our patients, of our carers, of our peers, our colleagues, what we read in the websites, what we hear from experts, from education days, and so on, and so on, and so on. There are many, many sources of evidence which we have to take account of as we do our work as clinicians. So how does the new research fit in with what the practitioners already know? And that's where the idea of mindlines came in. The way that we came across mindlines was through ethnography, through actually sitting with a practice that we call Lawndale, deliberately chosen as the best practice in the region on all sorts of measures and criteria, an 8-partner practice, rural. We did an ethnography for 2 years. We were following surgeries, sitting in clinics, sitting in the coffee room, observing them. And actually that went on for even longer for various reasons we won't go into. But we stayed for altogether 8 years in the end, watching what was going on in an ethnographic way, doing interviews and observing and just being around. And then we did check ethnographies in a different practice, in an urban, again, a very highly rated urban practice, university practice. And then we did the usual kind of thematic analysis. And then because of what we were finding, we started to look at other things like hospital doctors in the USA, as it happened, and students in training.
So largely this work is based on practitioners, and that's why it's relevant today.
What is a mind line? I'm sure some of you will already know that we called it an internalized, collectively reinforced, partly tacit, partly explicit, guideline in the head, hence the pun mind lines, that clinicians actually use to guide that very complex practice because of all their multiple roles. And it's informed by those many sources of evidence, not just the research that we researchers like to think they use, and we guidelines producers like to think they use. It's one person's embodiment of what we like to call their knowledge and practice in context. This is not the theoretical knowledge, neither is it the simple knowledge in practice that people like Polanyi have talked about for decades, or decades ago, but it's knowledge and practice in a particular context. You have to be flexible and malleable and practical in that context in order to do the right things at the right time. And that's where a mind line comes in, acting very rapidly to allow you to recognize much more complex patterns than educationists usually think of in terms of the heuristics and illness scripts and the rules of thumb, as some people call them, that all clinicians have, which educationists will know about. It's much broader than that because it involves all the other contexts that's around as well. So what are the things that are in a mind line? Well, obviously there's the embedded science, and I say obviously, but the practitioners themselves, when you ask them, often say, well, that was all a waste of time, I'd never use it. But of course they do, because it's deeply embedded and it's structuring how they approach things. They do have the rules of thumb and the heuristics and the illness scripts, and they've developed technical skills, but also as they've gone through their careers, they've developed the soft skills and the practical skills and the tacit and experiential knowledge that will enable them to make those decisions rapidly and flexibly. They will have taken on board their teachers and trainers' norms and views. They'll have learned what's done around here, the local norms and routines and the role models that they admire and people that they want to be like. And they'll have picked up institutional culture. We don't do that here. Okay, I'll do something else. Peer values. And of course, in there are the guidelines. What you don't see is research evidence. People don't talk about research evidence. And our job as researchers is somehow to weave the research evidence into this complex mess. Just important to point out, it is not a question of guidelines or mind lines, which unfortunately our first paper was entitled. People do embed the guidelines into their mind lines alongside the tacit and experiential knowledge and everything else. So the sources, well, you can imagine what the sources are. It's all the education and teaching and training and textbooks, but it's also what's in the media. Doctors and nurses and other practitioners, they read the newspapers and watch the telly as well. They read journals and also ordinary magazines, but they also listen to opinion leaders, to what they always talked about in their meetings when they're developing policy. They say this is the way to do things. Never quite sure who they is, but they is very important. And they help to shape your mind lines. There is, of course, the central guidance from NICE. Whoops. There is the local guidance and so on. But again, with all these things, including the drug reps and patients' views and your own experience, no real mention of research as such.
Which makes it, of course, very difficult for researchers to move the knowledge that they've generated into practice and know that it's moved into practice.
So here's our compost heap from some years ago, and into that compost heap, and this is the analogy, go all of these sources of knowledge that we talked about earlier. And somehow they get within the practitioners' minds converted into this magical knowledge and practice in context, which is embodied in the mind lines.
And of course, it's not just simply one individual's minds, but it's a process that is shared, knowledge is shared amongst practitioners to make collective mind lines about how to do practice in a team, how to do practice in a general practice. So exposing those collective mind lines, talking about them, is really critical. And if you're interested, you can read more about that and our earlier slides in that book.
One of the things that happens to knowledge as it gets batted around in this process is that it doesn't do what people expect, which is simply to go through the system and get used. This diagram is based on some work we did with commissioners, with health service commissioners. And their view was that they pick up knowledge from research-based guidance and so on, and they commission it, and the practitioners will simply, and the providers will simply put it into practice. But what we found was that in reality, it gets batted around all sorts of different demands and constraints and resource problems and all the things that we're all very familiar with. So the evidence that actually gets put into practice, the practice that gets delivered as opposed to what the research suggested, does end up transformed into something that looks very different from what the researchers originally thought. And this is a very nice example of that. We did a study a few years ago of the introduction of treatment centres into the health service. And this diagram really says it all. You didn't read the book, just look at the picture. Each model, it represents one of the 8 case studies that we did of a newly introduced treatment centre, which looked very different from the others and very different from the blueprint that had been driven by government and by the Department of Health. Due to the environmental uncertainty and the local internal constraints and demands, there was enormous variation as the evidence about the usefulness of treatment centres got changed and transformed. So the summary of the mindlines model is this. Context is massively important. People use knowledge in practice in context, which makes them what we call contextually adroit. In other words, if I have knowledge in practice in my context, if you put me into another context, even though I'm expert in the clinical subject, I will flounder for a while until I learn how things are done around here and what the resources are and so on. So you have to be contextually adroit. This is all based on accumulating multiple sources of sometimes tacit evidence, learning through practice, and learning collectively through communities of practice, which may or may not help you to share knowledge and experience. And important in this is the part played by clients and patients, which we won't talk about much today because you have that in other seminars in this series. And the final point to make is that formal knowledge, when it's put into practice, is therefore transformed into something different by all these influences. The way we sometimes describe this is like a pinball machine, where you put the ball into the machine and it bounces around between many different actors in the system, all with their own different mind lines. But the catch is this: you don't put in a steel ball bearing that bounces around and comes out the bottom eventually when it's finished. You put in a piece of putty, a putty thing, which as it goes around changes each time, because each of the actors has a different view of what counts, what's important, different other sources of knowledge they're melding it with, different mind lines, and that will change the evidence and transform it in the way that we talked about. The question that we're sometimes asked is, well, you did this 20 years ago. Is it still true? There's the internet now, surely. Well, we're about to produce a new book, an edited book. Sorry about all the book plugs. That's not a good idea. But anyway, we've reviewed about 1,000 publications in order to bring things up to date. And we're pleased to find that nobody's actually contradicted our work. A number of people have followed it up, including Epling, who I mentioned earlier. And what they found is that the rise of online information, of course, has made a difference. People gather their information, and that should now be very high on the list of sources, but it has not changed the role of mindlines. People still do very similar things to what we saw. Of course, people have used the mindlines model in many different ways. You'd expect that from our own model. They've modified it and truncated it and distorted it in all sorts of ways. But generally speaking, several studies have successfully used the mindlines model to explain what goes on or to alter practice, as we showed earlier with Dr. Epling in Virginia. And it's been applied across many disciplines and roles. The one thing that really has distorted the view is that quite a number of people think that it's a form of, those of you familiar with Kahneman's fast and slow thinking, that mindlines are system one thinking, that they're heuristics, that they're subject to those biases. Mindlines are not the same as system one thinking, for those of you who know about that. They're somewhere in between system one and system two, because they are a very fast and frugal way of working, but they use very carefully long garnered, hard won system two thinking that informs that system one thinking. So it's a different kettle of fish from those problems. here's a quick plug for the book, but more importantly, Andrée is going to tell you about a couple of studies in that exemplify what we're talking about.
So there are a couple here, one by Kate Beckett, one by Fiona Cowdell, both of whom have been knowledge mobilisation fellows in the past. And they show how mindlines are actually used to innovatively change practice, how they help to understand practice. In Kate's study, certainly how she has blended together research knowledge, mindlines from research, let's say, practitioners knowledge, mindlines from practitioners, and also patients and service users and their carers knowledge, mindlines from that group of people to blend something which could be actually used to change practice. And Fiona similarly has brought together mindlines to again blend something that would change practice. And the important thing here is to think through how mindlines can be used, how you can get your research into practitioners' mindlines and therefore change practice. If we're going to implement knowledge, implement research, we need to tie it together with action. And that's why we're putting the next slides here for you, so you can think through the change methods that might be used. So research needs to maneuver its way into people's minds. It has to compete with other sorts of knowledge, and it will be transformed. Those are the things you've gathered from the first section. Here we've trying to show you a method which will help you to do that, to get people to articulate what's in their minds, to think and critically appraise research, and to think how that could be moved through into the context of their practice. It's a relational method. It is largely using communities of practice, but it requires some facilitation skill. It requires some guidance and some management. And this is a method that we used in the east of England when we were the joint implementation leads there. So it won't be much of a surprise to hear me say implementation is fundamentally all about people, and therefore it's about understanding the mindlines of those people. Today we're talking about practitioners, but as I said before, everybody has mindlines. So if you accept that everybody has mindlines, you need to move research into those mindlines, then you have to start beginning to interact and communicate with the people in the community of practice that you want to influence in an effective way. And the principles that we use to encourage that effectiveness are being respectful, inclusive, encouraging cooperation, collaboration, and having what we call robust yet supportive dialogue. Working together, and this is practitioners, and clients, service users, and researchers, managers, everybody that needs to be working together to make a change is really important, because it actually solves real problems. And sometimes researchers are felt to be out of touch with the real world, but becoming part of a community of practice that is trying to put research into practice allows researchers to move into that zone as well. This requires proficiency, though, in 3 areas: interpersonal and organisational skills, technical skills, and learning and doing together. And sometimes researchers don't have those skills, so they need to gather together knowledge mobilisation specialists who do and work as teams with practitioners. So here we bring together the 4 circles then to make sure that the key people are in our communities of practice, so that we can evaluate and meld the widest range of relevant evidence. We need to help everybody understand the context in which that evidence is going to move into, because if you don't understand the context, you will come across unnecessary barriers and you won't be as effective as you might be. We need to ensure that all key people are involved, including dissenters, and learn from each other.
It's very important to stress here that we're not talking about us the researchers or the policymakers telling them how they should be doing things. It's about getting everybody to be able to express their views about what's good and bad about this new idea and how it may or may not work in their context.
And we need, because that's important, to promote full engagement and facilitate relationships that bring together purposeful, agreed change and action. So we've been using facilitated communities of practice to do that. I'm sure many of you know what communities of practice are, but I'll just give you the best definition that's around, really, which comes from Etienne Wenger and his colleagues. So they're groups of people who share a concern, set of problems, a passion. They want to deepen their understanding and knowledge in an area, so they interact together. They don't necessarily work together every day, but they can do. But they find it very useful to get together in their interactions to share their knowledge and experiences. So they spend time together, information is shared, insight and advice is also shared, and therefore they solve problems because they understand the context of those problems, and together they help each other. So that sounds absolutely wonderful. They're helpful, as I've said, in getting together to develop best practice, but they're also really helpful in implementing and reshaping knowledge and promoting learning, problem solving, moving knowledge and innovation into practice, and giving members ownership of the changes that are being made to practice. This is absolutely central to success, the ownership of those changes. But they can actually also be quite unhelpful because they can block the spread of knowledge by creating rigid boundaries around that community. They can perpetuate bad practice as well as good practice, particularly if the community doesn't have any mechanisms for appraising the ideas that they're sharing. And they can perpetuate groupthink and obviously become an echo chamber. So a good thing, a good means of developing relationships, of moving knowledge around, of integrating research findings with other sorts of knowledge, but also be cautious. Always encourage critical, robust dialogue in those communities.
We've got a little cartoon that describes how we used to do this. We'll show you some of it now. I think we've probably got time to show most of it.
At the East of England ARC, we make great efforts to implement research into practice. The ARC's job is to do applied research that helps solve problems and improve services using sound, scientifically researched evidence. And the ideal researcher uses co-production methods, working with all the key people who might be expected to use the results in practice. Well, the research may have yielded useful findings, but now what? How will that make a difference in practice?
Meanwhile, the practitioner and their organisation have a problem rather like the one the researcher worked on. The ARC, through its close links with both parties, spots the opportunity to apply the research findings. The ARC's implementation team bring together the researcher and the practitioner. They explain their ideas and talk through the possibilities. Then the implementation team consider whether the research findings and the organisation meet the ARC's criteria for an implementation project.
They think about the potential for implementation and who will need to be involved. If it looks promising, and with the senior executive's blessing, all the key relevant people are invited to form a community of practice. Service users, practitioners, managers, commissioners, whoever matters to making it work.
The facilitators ensure there are respectful, critical conversations to help people in the community of practice form relationships, often new ones, that enable them to share their in-depth, first-hand knowledge of the likely implications of the research. So they all learn about the good and the bad points of the research if applied in their context. They collectively explore the likely opportunities and barriers and who else needs to be involved to help the change happen, and they agree a plan.
As they set about the tasks for real, they inevitably have to tweak and reshape things, changing the planned implementation of the research to fit the context. They assess how it's going by using success criteria that they themselves have agreed. Usually they realise that they need to adapt things, both in the research findings and the context where the findings are being implemented.
The community of practice, who usually meet around 4 times, continue to check out and adjust things based on their agreed measures of success. This becomes a cycle of small tests of change. Our emphasis on personal and organisation relationships is crucial. The relationships help the key people become more committed to the project and to recognise that adjustments are needed on all sides. They know now that to keep making it work, they need to keep learning from each other, which is what being in a community of practice is all about.
They eventually agree that they've sustained the research-based change that was needed. The organisation's performance is improved. And the researchers and practitioners, and indeed all the community of practice members, have learned something and made tangible research-based improvements. Everyone's pleased, especially the people who use the service.
Every project is different, and everybody learns. The implementation team discovers something new each time and spreads these lessons across the ARC, growing implementation skills and capacity.
Practitioners and service organisations are encouraged to spread not only the research evidence as appropriate, but also the implementation principles they've learned about. And the researchers take the lessons back to their colleagues, so developing more collaborative applied research that can be put into practice.
Please get in touch.
If you want to see an example of how that worked, there's a very long URL there, but we'll be sending these slides around, and you can get to it quite easily by looking at the projects on the ARC website implementation part of it. This was a project that we did to introduce one of many projects that we're involved in, but this was to introduce what's called positive behavioural support for children and young people with learning disabilities, and particularly with challenging behaviour, who are the ones who are usually sent off to out of area, very expensive and not always very pleasant environments that aren't conducive to their well-being or that of their families. Positive behavioural support is a research-based or well-evidenced method of avoiding that, which not only improves their lot, but saves a lot of resource and a lot of money, because it's very expensive to send them away. And you can see how we implemented that, bringing together all the key people, and we now have there is now a new service in Cambridge and Peterborough of positive behavioural support, which is supporting about 16 kids and is saving between £1 and £2 million a year, as well as improving the quality of life for them and their families. And there will be a film about that shortly available. So finally, the principles of our work that we just wanted you to take as the take-home message. Research uptake is not a linear rational process. It's that WYSI diagram we showed earlier. Findings are melded from research with many other sources of knowledge. They're shaped by multiple contextual pressures and tensions. They're transformed into what we call knowledge in practice in context, and they do that satisficing that was shown in the little diagram of the commissioners changing the research to satisfy all the difficult situation they're in. Each actor transforms the knowledge, as we saw in the implementation machine, the pinball machine, and their different understandings change the outcome, as we saw with the treatment centres. And the way that all happens is mediated by these individual and collective mind lines that embody that process.
So communities of practice can play a crucial part. Implementation is fundamentally a relational activity, and implementing knowledge needs the right sort of skills. And here's a list of the skills that we consider to be essential ones. I'm not going to go through it, but you can see that it's got the implementation word down the side, just as a hint for what they are. So I'll just leave that there for a second while you read through yourself.
And this is why we're always rather skeptical when people talk about implementation science, because it's an art and a craft. And here's a final plug for something that is just about to be launched, which is our new implementation art. Is implementation a science or an art? In our online implementation art gallery, it's both. We've been helping people in the ARC East of England to implement research, and this gallery explains how.
You can go into as much depth as you want. The first room introduces our relational method, including an animation. If anything intrigues you, you can find out more by clicking on the icons.
There's also a downloadable workbook if you want to use this to further your own implementation skills.
You can learn more about the stages of implementation work, including from participants' own video clips, and there's a serialised story that takes you through the whole process.
And you'll find a room with our top tips about some of the craft involved in the art and science of implementation. Just go to the Arc East of England website, look for the implementation resources, and wander around the gallery seeing how you could make this relational method of implementation work for you.
It's all free, by the way, funded through the National Institute for Health and Care Research.
So we hope you've enjoyed the presentation. We hope it's helped you understand how practitioners think in practice and how research needs to manoeuvre into their mind lines and meld with other sorts of knowledge so that research can be moved into practice and implementation can be successful. Of course, we put that slide up there to thank everybody that was also involved with our work, because it isn't just ours. And we'd like to invite you to ask questions now. So we'll hand back to Helen.
So just a kick-off question while everyone does the voting. What key things do you think researchers need to know about how to mobilise knowledge with practitioners in order to maximise the usefulness of their research?
I'll kick off with that then. I think it's about understanding the relevance for practice. So I think it's about talking with practitioners, to selling their research to them and listening to what they have to say about how useful it is and how they might transform it. And I think researchers need not to be so afraid of transformation.
You mustn't be too precious about your research results. You must recognise the context and work with people. And I would say the single biggest practical thing I would say is, if you're doing research, try and do it in a co-productive way. Try and do it by involving the practitioners and the recipients of the service, the patients or whoever it might be, really early in the process, so that the research becomes relevant and so that they own it and feel involved and they can contribute their thoughts about the context all the way through. That's a really good way of making sure things get implemented. Also bear in mind that not all research needs to be implemented. Sometimes it's not the right thing to do. We are often too enthusiastic to get our research into practice.
And the other advice I think I would give is to pal up with other people who are skilled at doing the things that sometimes researchers aren't skilled at, because that can make a really powerful team.
That's great, thank you. Right, the top question from the audience, is a deliberately created community of practice as effective as a naturally occurring one?
Do you know, when we first went into this field, we actually went and sought out Etienne Wenger and asked him that very question, because we were a bit worried about that. And he said, absolutely, there's no problem whether it's deliberately created or whether it's natural. It's still a community of practice. It still works. And that's what we found. The important thing is that any community of practice needs to work effectively, and facilitation is often a very important part of that. Whether it comes from you or from somebody in the group as a good natural facilitator doesn't matter, but you have to get that robust, critical conversation going somehow.
And sometimes it's important to start something off, to construct it, let's say, but it takes on a natural life of its own, so it continues.
Great, thank you. And they're moving around. The next question, how do we facilitate mind lines in de-implementation of deeply embedded practices that are not evidence-based?
Very good question.
Yeah, absolute challenge that, isn't it? And I suppose that is sitting down and trying to expose those mind lines, to ask people how they practice, to draw out the tacit knowledge that often guides practice, and to understand that. So constantly ask questions of a group of people, and then think about how you can stop that practice.
Also, you may be the only one who thinks they should stop it, or you may not be. It may be that the patients and the managers and others are also, and maybe some of their clinical colleagues are also wanting them to stop it. So by forming a community of practice and getting people to listen to each other, you may find that you've got terrific allies who can share their mind lines about the way the things are being practiced, and that might help to persuade the perpetrators of the non-evidence-based and what you consider to be unuseful practice. So harness other people and expose mind lines from all quarters.
And perhaps formalise them sometimes through audit as well. So you can begin to show more openly and obviously what is happening and what happens in improvement. So small tests of change, again, decommissioning, deusing, if you like, whatever the word is.
Great, thank you. Next question. Do you have any thoughts on how the move to remote working, where colleagues are no longer in a shared physical space, has had an impact on mind lines and the implementation and spread of research evidence?
I don't think we can say too much about how it may have affected people's mind lines because we haven't really had a chance to look at that. But what we can tell you is that quite a few of the projects in the Arc East of England were done during the COVID lockdown. Some of them were entirely done by people who worked online in their communities of practice. We've never actually met them face to face. We did actually accidentally bump into one the other day, but it's the first time we've met her face to face. We've been working with her for 2 years. So it can work, and communities of practice online, if they're properly run, can be brilliant, and in some ways easier because people can get to the meeting, whereas they'd have had to travel across the region and may not have come in the normal run of things.
It's about skill facilitation, actually. That's a really important thing, and therefore it's about practicing those skills. Remote skilled facilitation is pretty hard, and it's very important though. One project that we were involved in, where we actually did ask, we said, how's it been doing this remotely? And they said, actually, it's better. We feel safer. We actually can be more open on the screen, partly because of facilitation, but also partly because you haven't got to sit next to the person in the next meeting again, or interact with them over coffee. You can say whatever you want, and it can be safer so long as it's handled and there's space outside to deal with any challenges.
One thing I'd like to add about the shared physical space is that there's been a tendency in the health service and universities and elsewhere to try to limit what they regard as redundant space, like coffee rooms. I had to fight like hell in an academic department to keep the coffee room so people can chat together. You do need that. And online, you don't have that. You don't have the informal chat. So it's a good idea, just as you might create a coffee room or a water cooler space or somewhere to chat, it's a good idea to try and create informal gatherings online of colleagues if you're all working remotely. Otherwise, you do lose that opportunity to share ideas and do the storytelling that leads to the mind lines and the changes in mind lines.
If anybody's interested in getting our book later on, you'll find a chapter in it which talks about how emergency doctors in New York formulated mind lines remotely around COVID, using WhatsApp and any other remote way of communicating that they could find. That probably gives you as much indication of how useful it is as anything that we could say. Not necessarily plug for the book, sorry about that, but it is a really great chapter to read because he really gets into how quickly and swiftly you can gather knowledge and critique it and then apply it, audit it, and feed those findings back remotely.
This was during the COVID surge in New York, a couple of intensivists talking about that. I think you've frozen, Helen. We can't hear anything or see you move.
Or we've frozen. Lindsay?
Hi there. Shall I ask the next question that's
Lovely.
been
Okay.
upvoted? Thank you. So next question is, there's no reference to power in the model discussed. What do you think the role of power is, and how can this be dealt with?
Huge. And sorry if we didn't mention it. It is really important. Andrée.
I think when I talked about ownership, I also had power in my mind. So yes, power is really important. But the important thing is that power may not be vested in the people that you think are powerful. So a small anecdote here from the study that we did where we looked at knowledge and older people's services, and there were very powerful people in that room, chief executives, but actually the most powerful person in there and the most influential and persuasive was an older lady who understood her community and was extremely good at convincing people to do things via cake baking. So we were actually amazed at the power shift that we saw from the chief executive to the person who understood her own community and the information she could give. So I think power is very important, but we have to be very careful about who we think is powerful, and using relational methods, talking things through, helps us actually find out where the power lies.
That's a really important part of the facilitation, which a skilled facilitator will make sure that the really powerful people are somehow persuaded to listen and are somehow kept in check. And you do have to do that. And thank you, whoever asked that question, for reminding us that we should have said more about power relations, because it is, of course, critical, as is resource and money, but which we also don't talk about.
Thank you. I think Helen's back now, so I'll ask Helen to take over with the questions again.
Sorry about that.
No problem.
The next question. Does this approach work still in scenarios where it's a definite top-down national policy level directive, the thou shalt?
Yes, we've worked with those sorts of things. But it's another thing it's worth saying. We've talked about the relational method, but there is also the just do it method. Sometimes it's an important thing. It's quite simple to put into practice. It's just do it. You don't have to always go through all of this. And a lot of the thou shalts do fall into that, but let's be honest, a lot of them don't.
And let's not forget that the thou shalts require some planning as to how to do them. They require people to come together and to work it out. And it is also about relationships, isn't it?
How shalt thou? You know, how is it actually going to happen in practice? And it's not just thou, which is singular, it's you, plural. How are you going to make this happen? And that does require the sorts of methods we've been talking about, even though it's a thou shalt do it.
This is a really important point. So thank you very much, whoever asked that, because we don't want you to think that implementation is all soft and fluffy. It can be directive, and that's entirely appropriate.
Sometimes.
And sometimes the thou shalts need to be done in a different way in different contexts. And that's why finding out about the context, the people, the evidence is all really important to the change method.
Okay, so the next question's from Matthew, who highlights, can't argue with anything you've said, but it's very resource intensive, and these things are in quite short supply at the moment in the NHS. It's difficult to know whether funders are really able to or convinced to pay for some of the additional work over an extended period of time, which could take months or years after a project.
Yeah, Matthew, you're absolutely right. You are right. It is resource intensive. We are in a resource strapped environment, but that doesn't mean to say we don't need to be innovative. And we can discuss research, think about implementing research at team meetings, everyday team meetings that we have once every so often. Bring a piece of research and think about how we might implement it. So it's really important to begin to move those methods into everyday working. My first job in research in the 1980s was responsible for putting research methods, research findings into practice. I had no resources. The only thing I had was my time. And what we found was really useful was to go around at team meetings, beginning to talk through research and encouraging people to find research. So this is about researchers actually making their findings accessible to practitioners. If you can give your findings to practitioners in the most accessible way, then they will use whatever resources they have to implement them if they find that they're relevant.
And don't forget, you can save time by doing this, because if they do rapidly start to implement something that will make their lives easier, in the long run they'll be saving time. And also don't forget that doing it remotely can save time as well, as we suggested. People don't have to necessarily travel unless they're already going to a meeting.
And the other thing that we hinted at the start was talking about the readiness of research to be implemented. One of the things that again is important that practitioners often don't have the time or resource to do is to say how the research findings, once implemented, affected practice. So essentially some quick evaluations that are made available to people, and that could be in blogs and all sorts of various ways, so that other people can benefit from their knowledge.
Okay, so the next question is from Christian. Very much in agreement that research is not a linear process, but does that mean that it's sometimes the job of the researcher not simply to get research into practice, but to help those in target setting to do better research themselves? After all, they're the experts in their own setting, so maybe they can be helped to develop their own solutions to their own problems in real time and with the facilitation of researchers.
Great idea. That sort of participative work, action researchy work, very, very important. I think that's a brilliant idea.
And it's not always the job of the researcher to get research into practice, because firstly, as we've already suggested, not all research needs to be put into practice necessarily. It may not be appropriate to do so at the stage that the researcher's just done the work. And secondly, researchers don't always have those skills. We all have different sorts of skills, and many, many researchers would need to work with others to do it in any case, because they just aren't very good at it, to be honest.
And thirdly, they don't necessarily know the context in which the research is going to go, but the practitioners do, and they know the problems that they want to solve, and so they're probably in a better place to do research themselves if we can encourage that. So buddying, palling up, excellent ideas.
Just let me row back from what I said before. Some researchers are brilliant at it, by the way, but not everybody.
So thank you for that. The next question is from Bruno. What is the difference between contextual adroitness and local culture?
Okay, contextual adroitness is in the person. The person is adroit. They are able to operate within that local culture. So it's the person and the environment they're in. That's the difference between the two. And obviously the contextual adroitness depends on that local culture. But also the local culture is developed by the people who are being contextually adroit. There's a subtle relationship there, but they are quite different.
Thank
I
you.
hope that's clear. If it's not, Bruno, stick another question in and we'll try and clarify it.
Next question. How do you think the use of social media will change how practitioners share knowledge? And how can researchers tap into that?
That's a tricky one. My first answer is to say, well, there has been research on how people have used social media with mindlines. And as I suggested in the talk, it's just another source of information which people have to learn to appraise and to use and to feed into their mindlines. I'm not a social media user myself, so I'm the last person to be able to answer this. Andrée, you're not either, but you do more than I do. What do you think?
I think social media is very useful in terms of awareness raising. And I think you can get group chats also using Twitter and other sorts of social media where you can discuss what's going on. You can be critical, you can have that robust dialogue about research. So it's about getting research out there quickly. It's very useful to do that, but it's also got to be coupled with the robust dialogue, because we know that we can get anything out there quickly, can't we, on social media, and it may not be the right sort of thing, it may not be quite good enough, but we again need to encourage the back evaluation back into the system. So social media is quite good for conversations.
Great, thank you.
I've just seen a question I need to clarify. The woman didn't suggest we all did cake baking. She just brought cakes to the meeting and buttered everybody up that way, so they all listened to her. That's what Andrée was talking about.
So I do feel cake baking around research would be a really neat idea of grabbing somebody's attention anyway.
Yes, that's one to remember. A question from Constantina. Where are the end users, service users and carers of the evidence transform knowledge, practical application of the evidence in these models?
They're in them, absolutely,
right,
implicitly in them all the way. It's just today we were asked to talk more about practitioners, so we didn't emphasize them. People using services have mindlines too, and they have to negotiate with practitioners a way forward which is appropriate for their mindline and the practitioner's mindlines.
There were a couple of slides that we took out because it was going to be too long, but they are about how the mindlines of the practitioners and the recipients of the care, the patients or whatever kind of care it is, interact to produce a different scenario for each individual case. Patients are absolutely vital in this, and they have to be, if it's going to work, nearly always have to be part of the communities of practice for implementation as well. That's
and obviously
important.
part of research teams when we're talking about co-production, because that can't be co-production without their input, but also experts by experience are doing a lot now in leading research, and so I think there's a shift in power in the dynamic.
That's great. Thank you so much. There are some more questions, so we'll try and deal with those by email. I can see a few coming up here, but we need to close now. Thank you so much, John and Andrée. That was brilliant. Hopefully everyone's found this webinar beneficial and can apply it in their own work. Thank you so much for your time, and I hope you all enjoy the rest of your day. Thank you very much.
Thank you all for
very
listening.
much.
Thank you. Thanks for having us.
Goodbye.